Hello all, this is Dr. Rupkumar. Welcome back to Masterclass series from Dentospedia. Today we are going to cover the second session of oral radiology, and today's topic is about X-ray projections. And in this session we are going to deal with both intraoral and extraoral projections. And before going into the main topic, I need you to understand few important points regarding X-rays. So X-rays are nothing but, they're kind of ionizing radiation and they're part of electromagnetic spectrum, right? And they are the waves of X-rays has photons, right? And they also present in particulate nature, okay? And photons are nothing but packets of energy without any electrical charge, and they travel at the speed of light, okay? And these are invisible, and it cannot be detected by any human senses. They have no mass or charge, okay? And they have high frequency and short wavelength. So because of these two properties, they have the power to penetrate the human tissues. Okay, and that is where we are using the radio diagnosis. Okay, and they diverge from the source, and it cannot be focused on a single point. Okay, and they have the capacity to get absorbed into the matter and have the capacity to ionize. So we have discussed, right? X-rays are kind of ionizing radiation. So they have the capacity to ionize the matter. Ionization is nothing but the process of conversion of an atom into an ion. Okay, and they can produce image on photographic film. That's why we are using X-rays for diagnosing conditions. Okay, and they can cause biological changes such as cancers in human tissues. And coming to today's main topic, in intraoral projections, we have mainly two kinds of techniques: bisecting angle technique and paralleling technique. So now we are going to discuss the bisecting angle technique. It is also called short cone technique, and it is based on a principle called Szyszynski rule of isometry, and it is advocated by a researcher called Weston Price. Okay, what does this Szyszynski rule of isometry states? Okay, suppose if you are saying two triangles are equal, they must have two equal angles and also they should have a common side. Only then we can say those two triangles are following the Szyszynski rule of isometry. Okay, suppose this is a rectangle triangle having an angle of 90 degrees. Okay, and if we place the two triangles side by side, they have a common side, right? And they have two equal angles, that is 90 degrees. So now we can say this slide or this figure follows Szyszynski rule of isometry. Okay, and also in right angle triangle, this is the longest side, and that is called hypotenuse. This is called base of the triangle. And now we dive into the application of this rule of isometry. So how do we use this kind of a rule in dentistry? So this technique is performed by keeping the film as close to the teeth as possible. So during the projection, we have to keep the film inside the oral cavity as close to the teeth. And the central X-ray beam is directed perpendicular to the imaginary bisector that bisects the angle forming a long axis of the tooth and the film. So here we are not projecting the X-rays on the basis of the film or on the basis of the tooth, right? Here we are taking an imaginary bisector, okay, that bisects these angles, the long axis of the tooth and the long axis of the film. And we are projecting the X-rays based on the imaginary bisector. Okay, we are projecting that perpendicular to the imaginary bisector. So in this figure, you can see this is the long axis of the tooth, right? And this is the long axis of the film, and they make an angle, right? And this angle is bisected by an imaginary bisector. Okay, we have to imagine that, and we have to project the X-rays such a way that X-rays should be perpendicular to the bisector, not in relation to the long axis of the film, not in relation to the long axis of the tooth. we have to project in such a way that X-rays should be perpendicular to this imaginary bisector. Okay, this is the application of Szyszynski rule of isometry. Okay, and here the long axis of the film is represented by AB, right? And the long axis of the tooth is represented by this line, and this A and C is the bisector. Okay, so here now you can see the application of Szyszynski rule of isometry. Okay, and in this technique we have two angulations, horizontal angulation and vertical angulation. Okay, vertical angulation is nothing but we move the X-ray cone up and down. For maxillary teeth we use positive angulation. For mandibular teeth projection we will use negative angulation. Okay, and in horizontal angulation we just move the cone left and right based on the point of interest. So in these both angles, vertical angulation is kind of important, more important than horizontal in this technique. Okay, we have to mainly focus on vertical angulation. So based on the area of interest, the vertical angulation changes. For example, if you are projecting, the point of interest is maxillary incisors, our angulation should be 50 degrees with positive angulation. Okay, so here we are projecting from upside down for maxillary teeth, and if we are projecting for mandibular teeth, we are positioning the cone from down to upside. Okay, now you might have known the difference, right? So for canines, maxillary canines, we must use around 45 degrees angle, that is positive angulation. For premolar, it is 30 degrees. For molars, it is 25 degrees. All are positive angulations. Okay. And for mandibular teeth, for incisors, 20 degrees angulation, 15 degrees angulation for canines, 10 degrees for premolars, and 0 or 5 degrees for molars. And you can observe all these are negative angulations. Okay. And how do we deal with the horizontal angulation? So the horizontal angulation should be adjusted in such a way that central X-ray beam should be centered to the point of contact between the teeth. So there is no particular, a protocol for the horizontal angulation. Okay, and we should keep the angulation, that is horizontal angulation, closely related to the point of interest. Okay, there is no particular protocol, so we must adjust with vertical angulation, and we must make use of best about the point of interest. Okay, and coming to the in this technique there are no special holders. So here you might have seen, right, patient is holding the film inside the oral cavity with finger. Okay, and if needed we can go for specialized holders if necessary. Okay, but not regularly used. And sometimes this technique is not followed usually because we are unnecessarily exposing the patient's hands with X-rays. Okay, so we have learned that X-rays are kind of ionizing, right? So that's why in few situations we don't use this kind of technique. And what's about paralleling technique? It is also called extension cone technique, right angle technique, or long cone technique. As the name implies, this technique is based on concept called parallelism. And the previous bisecting angle technique is based on the concept of Szyszynski rule of isometry. Okay, and in paralleling technique, the film is placed parallel to the long axis of the tooth, and the central X-ray beam is directed perpendicular to the long axis of the tooth and the film. So when we compare these both techniques, in this technique we are placing the film parallel to the long axis of the tooth. Okay, but in the previous technique, the bisecting angle technique, we have placed the film as close to the tooth as possible. Okay, and then the direction of beam. In this technique we are placing, or we are projecting the X-ray beam perpendicular to the long axis of the tooth and the film. In our previous technique, we don't deal with the long axis of the tooth and the film. We are creating an imaginary bisector. Okay, and we are directing the X-rays perpendicular to the bisector. Okay, here there is no concept of bisector. That's the main difference. You can see in this picture, you can see this is the long axis of the film, right? and this is the long axis of the this is the film, and this is the long axis of the tooth, and they are both placed parallelly to each other with the help of a specialized holder. Okay, and we are projecting the X-rays such a way that it is perpendicular to the both long axis of the tooth and the long axis of the film. So this is called the concept of parallelism. Here, the tooth and the film are placed parallel to each other. Okay, and then we are projecting the X-rays perpendicular to both of them, and we are using specialized holders for this. So, for example, ring XCP instruments are kind of a specialized holders for this technique. You can see the patient is projecting with the X-rays, and film is placed inside the mouth with the help of holder. Here we are not using the finger holding method like in previous technique. Okay, and when compared to paralleling technique, it gives much more information with clarity and good images when compared to the bisecting angle technique. We will get more resolution and we will get less errors in this technique when compared to bisecting angle technique. And coming to extraoral radiography, usually we go for skull radiography in maxillofacial region, especially for fractures, tumors, cysts. Okay, and this is a common radiography which we use in our dentistry. Here you can see the number of various number of techniques for skull radiography. Here we have lateral cephalogram, submental vertex projection, Waters projection, posterior anterior cephalogram, reverse down projection, okay, and also oblique lateral projection. And among these techniques, we place the patient's head onto the film and then we expose the point of interest, okay, and these techniques differ in head positioning, okay, and also the area of interest. Coming to the lateral cephalogram, in this technique, we are placing the patient such that film is parallel to the mid-sagittal plane. This is the mid-sagittal plane of the patient, okay, and film is placed parallel to the mid-sagittal plane. And then we are projecting the X-rays towards the film, okay, and this is how we position the patient, and this is the skull view, and this is a resultant image, okay. This kind of lateral cephalogram is commonly used in orthodontics in evaluating the patient's condition, okay, in evaluating growth of the patient, and also to mark the important landmarks in the skull region during the commencing the orthodontic treatment. And coming to the next projection, that is submental vertex projection. Here the patient placement is such that in a way like the canthometal line. You can see this is the canthometal line, this is outer canthus of the eye, and this is the meatus, external outer meatus, and this line is called canthometal line. Here we are positioning the patient in such a way that film is placed parallel to the canthometal line. This is the film, and it is placed parallel to this canthometal line. Okay, and we are projecting the X-rays perpendicular to the film. So in all the techniques, there is one common point, that is we are always projecting the beam perpendicular to the film. Okay, whatever might be the position of the head, we are projecting the X-rays perpendicular to the film. Okay, that's the important point. And in these two techniques, it might differ, but in most of the techniques, we are projecting the X-rays perpendicular to the film. Okay, and in submental vertex projection, here we are projecting the X-rays from submentum, that is on the mandible, to the vertex on the skull. So that's why it is named as submental vertex projection. And usually in this technique, it is commonly observed that zygomatic arch fractures are it is easily observed. Okay, that's why if we suspect zygomatic arch fractures, submental vertex projection is the first thing the radiologist advise. Okay, and coming to the Waters projection, it is also called sinus projection, and here the patient placement is in a way that the film is placed 37 degrees with the canthometer line. Okay, here this is a canthometer line, and this is a film. Okay, and film is placed in such a way that it makes 37 degrees with the canthometer line. Okay, and beam is always perpendicular to the film in this technique, and this is how you position the patient. And this is the skull view. Okay, here you can see maxillary sinus, frontal sinus, and sometimes ethmoidal sinus can be seen. Usually this Waters projection, okay, usually used for assessing the maxillary sinus pathologies. Okay, if there are any maxillary sinusitis, maxillary tumors, cysts, or any orantal fistulas, it can be seen in this technique. So various techniques have their own, they have their own area of interest. So based on the suspect, based on the point of interest, we should select different radiographs. Okay, and coming to the next technique, that is PA cephalogram. Okay, that is posterior anterior cephalogram. In this technique, film is placed in such a way that it makes 10 degrees to the canthometer line. So this is the film, and this is the canthometer line. Okay, and it makes 10 degrees with the canthometer line. And beam is always perpendicular to the film in this technique, and this is how we position the patient. Okay, and this will be the skull view, and this is a final radiographic image. And coming to the next technique, that is reverse tone projection. In this technique, the film is placed around 30 degrees with the canthometer line. Here we are we are writing it as minus 30 degrees because the patient is positioned downwards. Okay, negative angulation. The patient is uh, facing the head downwards. That's why we are naming it as minus 30 degrees. Okay, and also the patient is asked to open the mouth. Okay, here the patient is opening his or her mouth during the projection. Okay, this is a very particular point in this technique. Okay, and beam is always perpendicular to the film, and this will be the head positioning in this technique, and this is a skull view, and this will be the resultant image. Usually in this technique, we can observe the condylar fractures easily when compared to other techniques. Okay, and coming to the oblique lateral projections, we have mainly two techniques involved. When we need to see the body of the mandible, we use this kind of technique, and we want to see the ramus. If the point of interest is the ramus of the mandible, we will use this kind of technique. Okay, for body of the mandible, we should place the film close to the contact. Okay, we should keep the film in contact with the cheek of the molar area, and beam is always it is projected towards the film, and here beam is aimed at molar and premolar area. Okay, this will be the patient positioning. Okay, and this will be the resultant image where you can see the impacted third molar, dilacerated roots. Okay, this is the body of the mandible. Okay, and this kind of projection gives more information with the body of the mandible. And coming to the ramus projection, oblique lateral ramus. In this technique, we are placing the film in contact with the cheek at the ramus area, and beam is aimed at the ramus area. Okay, and this is how you position the patient. Here you can see the ramus of the mandible clearly without any superimposition and clear images. Okay, if you suspect any odontogenic keratocyst or any tumors in the mandibular ramus, this technique is very useful for diagnosis. Okay, and these are the various extraoral radiographic techniques used in the oral radiology. Okay, and this is the anti-scatter grid design, commonly called as grids. Okay, they are nothing but strips of lead. Okay, and these are commonly used in extraoral radiography, and we place these grids in between the patient and the film. Okay, and the main purpose of grid is to absorb the scattered photons. So scattered photons, they make the film foggy in nature. Okay, we can't see the structures clearly if there is any film fogging. So that's why we have to eliminate the scattered radiation. Okay, and the purpose of grid is to eliminate these radiations. And when we use these grids, we will get good clarity in the images. Okay, and these are commonly used in external radiographic techniques. So here you can see these H represents the height of the lead strips. D represents, so in between the lead strips there are certain materials, that is plastic. Okay, usually plastic material, that is radiolucent. Okay, lead is radio opaque. Okay, and in between the lead strips there will be certain radiolucent material, and that thickness is represented by D. Okay, and thickness of the lead strips is represented by small t. And you can see this is a block diagram. The primary radiation, which has the highest energy of penetration, will go through the lead strips. Okay, and they are usually in straight path. Okay, but the scattered radiation has, they don't travel in straight lines. They're kind of a oblique in nature. But because of their oblique nature of pathway, they hit with the lead strips and then they get absorbed into the strips. And by this technique, we can eliminate the film fogging. Okay, and we have various kinds of grids. So based on the structure. So in grids, we have certain characteristic feature called contrast improvement factor, where you know uh, an ideal grid should be capable of removing 80 to 90% of the scattered radiation. The resultant image thus has better contrast. This improvement in the quality is referred as contrast improvement factor, which is represented by the letter K. So the ideal grid should have high K value and it should be around 1.5 to 3.5. Okay, and these are the grid characteristics. T represents the thickness of the lead strips, H represents the height, and D represents the distance between two lead strips. Okay, and what is grid ratio? It is nothing but the ratio between the height of the lead strips and the distance between the lead strips. Okay, H divided by D. And what is grid frequency? It is represented by the formula 1 divided by T plus D. Okay, so this is how you place the grids in between the patient and the film. Okay, and when the x-rays are projected, the scattered radiation will get absorbed due to its oblique nature. Okay, and the primary radiation will pass through the lead strips because they have straight paths and they travel in straight lines. Okay, and what is grid density? It is nothing but the number of absorbing strips per 1 centimeter. We have discussed, right? The grids are nothing but strips of lead. So grid density is nothing but number of X-ray absorbing strips per centimeter, and the grids are available in densities like 34, 40, 80, and so on per 1 centimeter. Okay, and the higher the grid ratio, we get the better image quality with less visible grid lines. So if we are using higher grid density, we will get more clarity in the images. And we have discussed about the grid, right? And we have different types of grids based on the structure. And here you can see the first and foremost grid uh, that is made, that is called linear grid. Here you can see the photons, which has oblique path. They get absorbed into the strips, and those have straight paths, and they're getting they're touching the film. Okay. Here you can see this is another type, that is a focused grid. In this grid, you can see the lead strips are kind of angulated. Okay, in the center usually there is no angulation, but at the periphery you can see the angulation of the strips. Okay, and this is called focused grid. In pseudo-focused grid, the height of the strips is decreasing as we go from the center to periphery. Okay, and this is called pseudo-focused grid. In crossed grid, we have mainly two types of grids, that is placed perpendicular to each other. Okay, and this is called moving grid or Potter bucket grid, which is not commonly used in oral and maxillofacial radiology, but used in with the point of interest is other than oral region. Okay, so this is the film cassette where there will be intensifying screens on both sides, and in between them we are placing the film. Okay, intensifying screens, they help in they help in giving more clarity to the images. Okay, and when we use screen and film combination, we will get extraordinary results uh, in the image clarity. Okay, here you can see this is an intensifying screen and another intensifying screen, and in between them the film is sandwiched. Okay, so this is how you place the film and screens inside the film cassette. Film cassette holds both of them. Okay, and this whole setup is usually used in extraoral radiographic techniques, not in intraoral. Okay, and thank you. So this is all about Excel projections and its related topics. So let's meet again in another video. Thank you.